every country has its own way of providing health care. It's organized differently. The kind of data it has at its disposal is different. So there are many different ways in which countries are trying to do this. By and large, though, they tend to be looking at similar kinds of issues. But the way in which they do it is very different. So a country, for example, that has a single payer system is doing it very differently than, for example, a country that has a more fragmented kind of healthcare system. A country like New Zealand, for example, is able to collect similar data across the country from providers of care from the north and from the south in rural and as well as urban centers, and collect similar kinds of data to inform quality measurement. Other countries like the United States that are very fragmented can't necessarily collect similar data from the same kinds of providers all across the country. Some countries have it more based upon states or regions or provinces. Others have extremely good data systems, such as the Scandinavian countries, which have a great deal of individual data about individual patients, the kind of care that they receive, and in a way that's set up longitudinally across their lifespan. Others have more episodic-based information around a particular episode of health care, or maybe based upon insurance claims and are limited only to what is in insurance, paid for by insurance. Others have information from healthcare records that they're able to collect. But in some cases, it may be expensive to collect that data if it's not electronically based. And even if it's electronically based, it may be difficult to make sure that what you're collecting is information that's just about documentation or whether it's about what people really get. So it's very different depending upon the healthcare system that you have, the kind of data that you collect, and also what are perceived as the important needs of the population that are being treated. So it's important not to think of quality measurement for measurement's sake. It's important to collect information about quality based upon what you want to do with it. What actions can you take to inform various strategies for improving on quality? So there's lots of ways of doing that, but one can think of it in terms of 3 levels of improving quality: clinical, organizational, and policy. So at a clinical level, measuring the outcomes of patients serially, over time, longitudinally, in a systematic way, what people sometimes call measurement-based care, is a key strategy towards improvement. If you follow people over time, see if they're getting better, and if they're not getting better, using the measurement in an action-oriented way that allows you to make decisions if the patient isn't getting better, to make choices from a menu, if you will, of reasonable options based upon the evidence for intensifying the care, so-called step care models. This measurement-based care system has been shown to improve care on an individual level for patients, and it relies on quality measurement or outcomes measurement as a core feature. At an organizational level, you want to see how the organization as a whole is performing. You want to reduce variation among providers in the organization, and you want to take action to improve care using a number of strategies that have been developed around, oftentimes from industrial engineering techniques, whether it's called Six Sigma or the Toyota production system, or what people have termed PDSA cycles, plan, do, study, act cycles, for making rapid changes and seeing whether or not, evaluating whether or not those changes are actually improving things, and then instituting those improvements, and then moving ahead and continuously trying to improve. It's important that organizations and leadership within the organizations understand these processes and apply them effectively. At a policy level, we need to understand how the country or the province or the state is performing overall. And there we need to think of ways by which we can incentivize improved performance, whether by public reporting of measures, which gets at people's pride and sometimes shame with regard to how they perform relative to other colleagues, or with incentives that have to do with pricing and financial incentives, so-called pay for performance or payment by results. These kinds of incentives help to push people and push organizations to improve and apply these sort of organizational techniques for improvement. So there are several areas that need more attention. probably the most important one in mental health is around measures that relate to recovery. The notion that patients, what used to be called patients and now we call consumers or users of care, need to be at the central point of attention. As some people say, the consumer is really the true north of where we need to go in the healthcare system. How do we get measures that really get at what consumers want from their mental health care? And that's where we need to do a lot more work to better understand, number one, what consumers really want, and that's going to be often individualized, and number two, how can we systematically measure that using both structure, process, and outcomes measures. New Zealand has actually done a fair amount in that regard, and they've developed, as part of their recent commission reports and blueprints, have really focused on recovery as a major area where they want to invest in developing measures and applying those measures. A second area that's important to move ahead in has to do with comorbidity and the intersection between mental health and general health care. Clearly, there's a great deal of comorbidity between mental health and general health conditions. A large portion of the costs of health care for people with mental health conditions is on the general health side of things. But there's often a split between the providers and the systems of care for mental health and general health. What we want to do is develop better measures that document shared accountability for both mental health conditions and general health conditions. So that, and by shared accountability, what I mean is that if you're a primary care provider or a GP, you're equally responsible for the patient who has both diabetes and schizophrenia, for the outcomes related to their diabetes and to their schizophrenia. And if you're a mental health provider or psychiatrist, you're equally responsible as well for the outcomes related to both their schizophrenia and their diabetes. By having this shared accountability, that enforces a greater collaboration. But we have to have measures that measure both of those things more effectively. Several decades ago, a professor at the University of Michigan, Avidis Dhanabedian, developed a framework for how to describe and measure the quality of healthcare generally. He talked about having three buckets of quality measures, one being structure, the second being process, the third being outcomes. By structure, he referred to the fact that we need to know the extent to which the health system has the capacity to provide quality care. That is, are there sufficient personnel? Are the facilities set up to provide quality care? Number two, is quality care actually being provided? That is, are we providing care in a way that is consonant with the care that is expected based upon the research literature? Are we providing both psychopharmacologic and psychosocial services and team-based services that conform with fidelity to the evidence base that exists, showing those treatments that are most effective? Finally, there's the issue of outcomes. Are people actually getting better? Are they getting better not just clinically, but are they also getting better in terms of the kinds of measures that are important to them? It's possible to develop a whole lot of measures that measure structure, process, and outcomes, and to decide among those measures which ones are the best to use. So one can look at, number one, how important are the different measures? How important are they in terms of the prevalence of the condition and the prevalence of the issue? But also, how important are they to individual patients? Number two, we can look at whether or not health systems can improve on these measures. Are there things that they can do something about? Number three, are the measures actually measuring quality with validity? Are they associated with better outcomes? And then finally, are they feasible? Is it possible to get data to actually collect information about those measures? Or does it cost as much money to collect the data as it does to provide the care? One can go through those kinds of issues and come up with a set of measures, a measure set, that's balanced across structure, process, and outcomes that also meets those criteria. I think there are several reasons why society is turning its attention towards the issue of quality of mental health care. Number one, it's the cost of mental health care. There's greater recognition of the prevalence of people who have mental disorders, its impact on the family, the costs of providing care. Number two, there's the intersection of mental health care and general health care. People who have comorbid conditions, that is, mental health disorders as well as general health conditions such as diabetes, arthritis, cardiovascular disease, cancer, have much higher costs of their care than people who do not have a comorbid mental health condition. Number three, there are the hidden costs of mental health care in terms of disability, in terms of presenteeism and absenteeism. This impact is hidden in terms of the healthcare side, but has a huge impact in terms of employers and in society at large. There's growing recognition of the impact of that. In addition, there's broader recognition of the fact that there are problems in the quality of mental health care. And as these problems become more apparent, there's a need to figure out what we can do to improve the quality of care and what we can do about that. And finally, it's not just mental health care that's being moved into this whole realm of quality measurement. The healthcare system as a whole is being pulled into that effort. And mental health is getting closer and closer to the rest of healthcare, and as such is being pulled more into looking at the same kinds of policy issues that healthcare generally is dealing with, and quality is chief among them. So several years ago, as part of the International Initiative for Mental Health Leadership, a subgroup called the Clinical Leaders Group got together. These tend to be the key clinical leaders within a country, often chief psychiatrist or chief clinical officer within a country, responsible for maintaining the quality of care within that country's mental health system. At that meeting, there was a recent report out from the U.S. Institute of Medicine regarding the quality of mental health care, and looking at it from the point of view of what people have termed sort of the quality chasm. What is the big gap or chasm between the quality of health care that people have and the quality of mental health care that they should have? And a report from the U.S. sort of pointed out a way by which one can move ahead to improve quality. Out of that meeting, a group of these clinical leaders got together and decided to collaborate on a major project around measuring and improving the quality of mental health care. And this took on three phases. The first phase was to find out what was going on across all of these countries with regard to efforts around measuring the quality of care and various strategies that have been used and actual measures that have been used. And in that first phase, we identified and did surveys from the literature as well as surveys of individual countries about what they were doing. We identified about 650 different measures that were used to measure the quality of mental health care, and many, many different initiatives across these countries. For the second phase, we took all those measures and measure concepts and went through what is termed the Delphi panel process. That is, had a group of experts, these clinical leaders, rate these different measures with regard to their importance, with regard to their feasibility of collection, with regard to the validity to which they really represented a measure of quality. And based upon that, we identified a number of very highly ranked measures. We're now in the third phase, where we're actually in the process of working with the people in different countries to collect data on these measures, on the highly rated measures across all the different countries, so that we could begin to benchmark where different countries are and understand if there's differences among the countries in terms of these measures, what might be accounting for that, and what techniques or best practices have different countries learned to make improvements that other countries have not yet been able to do. So we're in the middle of this third phase. I'm glad to report that New Zealand has been very much involved at each of these phases and is really a leader among the clinical leaders group in doing this. And we hope to report soon on the outcomes of our third phase of this project.